Hello, everyone. Thank you. Good morning, and thank you for being here. My name is Vicente Garcia Tomas. I'm the Chief of Regional Anesthesia and Acute Pain at Northwestern Memorial Hospital in Chicago. And we are going to be discussing neurologic complications of regional anesthesia today. We have a great panel of speakers, and we're actually going to have four subsessions instead of three. So let's get started because there's a lot of content that we would like to cover with you. Our first speaker is Kaylin Saxey. She is a local. She's a regional anesthesiologist here at UT Health San Antonio, and she's going to be discussing an overview of neurologic injuries, classifications, and incidents.
All right, so I'm going to start with the intro. Here is our roadmap for today, and since we are short on time, I'm going to go ahead and get started. So let's first talk about how often these injuries happen, and it's actually not a very simple answer to the question. Why is it just changing on its own? Because they happen infrequently, and so it's very difficult to quantify. So we have a couple sources for the data. The first would be medical, legal, or like ASA closed claim data, and these are biased by the presence of an injury, and they don't contain a denominator. So we don't know how many blocks were performed in order to get these injuries, so you can't calculate an incidence from this kind of data. Then you have clinical-based data, where you can look at things like self-reporting, which are often biased as well, and we look at those versus things like prospective studies where we follow up every patient that got a block over time, and we'll see that in the prospective studies we often find higher incidence than just self-reported injuries after a nerve block. So given all of that, we have a wide range of incidences that are reported. Anywhere from 0.5 to 8 in 10,000 peripheral nerve blocks will result in some kind of peripheral nerve injury. And we see that this number has been relatively stable despite increasing prevalence of blocks and the increased use of ultrasound. The good news is that 10 to 15% of them will just be mild transient paresthesias, and that within a year, almost 99% of these injuries will have completely resolved. It is speculated that more proximal blocks like the interscalene are riskier than distal blocks, and this is because proximal blocks have a higher concentration of nerve tissue compared to connective tissue. And it's also important to remember that not all peripheral nerve blocks or peripheral nerve injuries are block related. So here is a study from the University of Michigan. They looked at almost 400,000 cases over a 10-year period at this large academic medical center. They found that the rate of nerve injury was 0.03%, and it was associated with hypertension and smoking, but not whether or not a patient had a nerve block. So not all nerve injuries at the time of surgery are related to nerve blocks. So here's a more recent publication in RAPM from 2023, and they looked at pooled incidence over time, and they looked at several different time periods. So on the far left, you see they looked at greater than 48 hours after block in that first 2 weeks, then 3 to 6 weeks, 7 weeks to 5 months, 6 months to a year, and greater than a year. And what you can see is that similar to what we talked about, this natural progression where blocks seem to be resolving, the highest incidence being in that first 2 weeks after a nerve block. Here they actually find a much higher incidence than other studies that are quoted. They're seeing almost 1%, 9 injuries per 1,000 blocks. But you see that as you go out to a year, those numbers have rapidly decreased. They then looked at that acute time period, that first 2 weeks, and broke it down by blocks that were happening. And again, similar to that prediction that proximal blocks may be more risky, you see that the interscalene has the highest incidence of injuries. In the purple there, that's the cumulative incidence, and then they broke it down in the blue when ultrasound was used, and in the red when ultrasound was not used, so just landmark guided technique. And what you can see is that there's a signal that maybe using ultrasound here for the interscalene block in particular is reducing the incidence of nerve block, whereas when you look at like axillary fem and popliteal, there wasn't much of a difference when ultrasound was used or was not used. Now let's look at the ASA closed claim data. So this is from all claims from 1999 to about 2010. So we're getting a little dated in our data here, but they had 189 nerve block claims. This is excluding neuraxial, eye blocks, and chronic pain blocks. And here's the blocks that were involved in the injuries. Again, most common is interscaling at 42% of the injuries. Then they looked at the type of injuries that they had. Good news that 2/3 are temporary and non-disabling. Somewhat concerning, 16% were permanent and 16% involved brain death or death altogether. 7 of those cases were in fact last. So the good news is that most of them are temporary, but again, interscaling showing that it may be one of the higher risk blocks. So now let's talk about nerve anatomy. So we have a very rudimentary drawing here of the cross-section of a nerve. So the most basic unit is going to be your axon. Now axons can be myelinated or unmyelinated. Either way, they're covered by a protective covering called the endoneurium. This is a thin protective covering that surrounds each axon. Now groups of axons bundle together to form a fascicle. And these fascicles are surrounded by perineurium. Perineurium, you can think of it kind of like your blood-brain barrier. It's an important diffusion barrier for medications that are administered around nerves. Now, surrounding the perineurium, you're going to see some connective tissue, fat, blood vessels, and on the outermost layer of the nerve, you have the epineurium. This is the thickest of the 3 layers. You think about this one kind of like your dura. The nerves have a dual blood supply. They have intrinsic blood supply, so that's within the fascicles there, and then they have an extrinsic, so underneath the epineurium and within that connective tissue. So how do we classify nerves? There are 2 classification systems, the Sunderland and Seaton. We start with our normal nerve here on the left, and you see that as you go to the right, you're getting progressively worse in your damage. So grade 1, we've lost the myelin sheath. Grade 2, the axon is gone. All of it is gone. Caesar, how do we go back? Okay, back. And then grade 3, we've lost now the endoneurium, grade 4, the perineurium, and grade 5, complete transection of the nerve. And you can imagine that as you move towards the right, as you lose more of those protective coverings, that the prognosis gets worse and worse. So if you completely transect the nerve, chances of recovery are quite low. Oh, now it's got a mind of its own again. Okay, all right. So now let's move on to the second or double crush hypothesis. So this was first described back in 1973, the idea is that nerves that have a pre-existing neurological compromise, so anything that disrupts axoplasmatic flow down the length of the axon, would put these nerves at risk for nerve injury. So the tricky thing is that some of these pre-existing conditions may be subclinical, so they're not immediately obvious on exam, but you can have mechanical injuries like a previous nerve injury from a nerve block or from a trauma, per se. There's ischemic nerve injury that could be related to microvascular disease, so diabetes, hypertension, smoking, tobacco use, peripheral vascular disease, toxic, so exposure to things like chemotherapy drugs, alcohol use, metabolic, autoimmune, so Guillain-Barré, post-polio syndrome, ALS. So any of those types of neurologic disease, whether clinical or subclinical, could put you at increased risk when nerves are exposed to another insult. So you can see here's like the little insult that's disrupting axoplasmatic flow, and then when you have another insult, now that nerve could lead to demyelination or denervation, where before, if it was a healthy nerve, it may have withstood the initial injury. So I don't know about you, but when you start hearing those things listed, you start thinking this may rule out a lot of my patients: diabetes, hypertension, tobacco use, peripheral vascular disease. So you're thinking, can anybody safely get a block? The good news is that ASRA has released some specific guidance in these papers here, these executive summaries. The long and short of it is that it should be an individualized decision between you and your patient. So you're having a risk-benefit discussion about, is the potential benefits of a block going to outweigh the potential risks of performing these techniques? If you want more specific guidance, in that second paper here, they do have specific guidance on several neurovascular diseases, things like spinal canal stenosis or inflammatory neuropathy. So if there's a specific neurologic disease that you maybe don't come in contact with all the time, that you can look to see what ASRA's guidance on is for providing a block. So now let's talk about classifying intraneural injections. It can be somewhat confusing in the terminology, but basically an intraneural injection is anytime you violate the epineurium, so that outermost covering of the nerve. If your needle violates that outermost covering, you are now performing an intraneural injection. But that's still kind of a broad term, so we further classify intraneural injections as extrafascicular. So this is injecting into this connective tissue, or intrafascicular, where you're injecting into those bundles of axons. And you might imagine that not all, that those might not be the same. So not all intraneural injections actually result in a detectable nerve injury, but it does seem that severe peripheral nerve injury does require breach of that perineurium, so injecting within the fascicle. So intraneural, intrafascicular injections are the ones that we're really worried about and trying to avoid. So in summary, peripheral nerve injuries are thankfully rare, 1 to 4 in 10,000. Most of these injuries are going to resolve over time. If your patients do have a pre-existing neurologic disease, maybe having an in-depth discussion about risks and benefits is a good idea before you perform any blocks, and that not all nerve injuries are caused by blocks, contrary to some popular opinions. So.
Thanks, Dr. Saxey. Next, Dr. Philip Lurk. So Dr. Lurk is also works in Texas. He is the Director of Acute Pain Services at UT Health Houston. He's also a professor of anesthesiology, editor of Current Opinion Anesthesiology, and an associate editor of anesthesiology. And he is going to be discussing intraneural injections.
You click on My Files there.
Must be there.
See the top, click My Files.
Okay.
Yay.
There you go.
Wonderful. Thank you so much. Thank you for the introduction, ladies and gentlemen. Good morning, and thank you, Kaylin, for setting this up, because so Kaylin is talking about the definition of intraneural injection. I get to take it a little bit further to say what happens and what are other mechanisms, how we could injure nerves during regional anesthesia. My name is Philip Lick. My accent may not give it away, but I'm a local Texan here. I work in Houston now, and I really love it. No disclosures, but lots of questions. And I would like to group my talk around 4 questions. So what happens when you inject intraneurally? Can you actually pierce a fascicle? And we for a long time thought that intraneural injection was so dangerous because you pierce those fascicles. So how realistic is it? There is some really interesting evidence on that. What mechanisms for nerve injury are related to regional anesthesia in general, beyond the intraneural injection, and how does central and peripheral injury differ? And that somehow closes the loop. And to what Kaylin just told us. And I think before we do dive into those topics, let's take a step back and just recognize one more time how incredibly complex nerves are. It's not just like an electric cable. They are very, very, very complex in terms of their architecture. Every nerve is a little bit different, has different tissue compositions. And I would just like to refer you to the work of Dr. McLeod and Dr. Reyna, who in the last 3 or 4 years have done a series of very thought-provoking manuscripts about how local anesthetic gets to where it needs to be and how the nerve is really architectured. They're using electron microscopy and high-definition ultrasound to redefine how we see our nerve blocks. And if you see this beautiful structure of a nerve, do you think, should a needle ever be in there? And the spoiler is no, unless you put it right here. This is a sciatic nerve between the tibial and the common peroneal nerve. Maybe that's the only exception here. But inside the epineurium, actually, no. And there is some evidence to support this. I'm just going to give you a few examples. The first is registry-based. So this is a registry from Australia and New Zealand colleagues, where they looked at the peripheral neuropathy. They looked at factors associated with the new onset neurological deficit, and basically the one thing that was associated dependently basically was paresthesia during the procedure, basically a zing down the arm increased massively your chance of having a postoperative neurological deficit. There is other data as well. I'm just going to stick to this one for now. The next step would be, is there experimental evidence to help us understand what's going on? And in interpreting all these studies, it should be worth noting what Dr. Seelander said in the 70s and 80s, that every regional anesthetic is a calculated injury to the nerve. We use toxic medicines with a sharp needle next to very delicate structure. So that's, I think, how we should approach our regional anesthesia. That's a level of carefulness that we should exhibit. Animal experiments showed something interesting. So this is just one of them. So this was large animals, ultrasound-guided regional anesthesia of the sciatic nerve. And several things were done to these animals. So 5 milliliters of saline extraneural, the needle just poking into the nerve being retracted, and then intraneural injection of saline. And what you see, not surprisingly, if you map the compound muscle action potential against time, if you have the 5 milliliter extraneural, nothing happens. If you inject into the nerve, a lot happens. So you basically decrease the compound muscle action potential in this nerve. This is all normalized to baseline. But interestingly, if you just put the needle in it and you retract it, it takes a little longer, but then you see a decrease in the CMAP as well. So this little injury here has profound consequences. And that challenges our old health pathophysiological view that the main noxious thing in an intraneural injection is the intrasacral injection, increased pressure and mechanical disruption, which is certainly a part of it. But it points to the fact that there may be something else going on, and that is somehow the novel hypothesis that there is at least a component, even if you're not in the fascicle, but outside of it, that there is a pressure increase, there is inflammation, there is a chemical process that's going on that exacerbates everything. And as every time in real life, probably it's a little bit of the same. So this is not an alert for nerve injury. This is not timed. This is not timed. So nothing, we're safe. So as every time in life, probably it's a little bit of both. Probably it's a mix of both. And then to what extent intrasaccular versus interfascicular injection is possible depends, like Kaylin said, on the nerve. So every time someone asks you about nerve injury, the safest thing is to say it depends on the nerve, because it's really so different. And you can maybe imagine here, this would be this would be a histological stain of a mono or bifascicular nerve. So this is like a cervical nerve root, for example. This is what we encounter in the interscaleal nerve block. And it's mostly nervous tissue, very little other tissue. And this is about the size of the needle projected into it, again, by Rayner and McLeod. And you see that the needle is big. If you do manage to get into nerve, if the nerve root doesn't move away, you're very likely to cause injury here. And now contrast that with the sciatic nerve. This is Moyayeri and Hun did these experiments. So you have a series of histological subgluteal, also intragluteal, subgluteal, midfemoral, and then popliteal. And if I direct your attention to the middle graph, you see here plotted at different levels of distalness, light gray connective tissue, dark gray neural tissue. You see that in the popliteal fossa here, we're actually talking about less than 40% of neural tissue and 60% non-neuronal tissue. So to stick a needle into that nerve makes a huge difference. And then there is a thing we can actually measure when we put the needle in these nerves. That would be what's called opening pressure, the pressure that you have on your pressure manometer. And we know that there is a difference in the type of needle you use. There's a difference in how much you inject. But then the huge difference is between nerves, right? So you can get different pressures with different needles. You inject more, you get bigger pressures, but the main difference is between nerves. So again, we just talked about the cervical and the sciatic nerve, and you see over here that the pressures that you have intra and extraneural for a cervical root are much, much higher that you get. So there is much more resistance, much more tissue resistance, whereas the sciatic nerve is actually relatively pliable, forgiving anatomically. So this 15 psi that's recommended as a universal cutoff for intraneural injection only does cover a part of that. And every nerve is different, so as a universal cutoff, it may not be perfectly suited. All right. So the first summary in my talk is that nerves are enormously complicated structures, which is amazing and beautiful. And every nerve is a little bit different, just like nerve cell types are just a little bit different. And peripheral nerves contain a variable amount of non-neuronal tissue. And as Kaylin said, usually the rule of thumb is the more distal you get, the more non-neuronal tissue you have. And then, as we know from ultrasounding these nerves, when you're in the upper extremity, the nerve roots, and even a little bit down into the axillary nerve, axillary fossa, there is less connective tissue. That's why they are hypoechoic. And there is more connective tissue where we go to the lower extremity, which is why they're hyperechoic. When you do get your needle in, there are two principal hypotheses for regional anesthesia-related injury. One is mechanical trauma, and then we said that there is increased perception that there may be a big component of inflammation and of chemical processes that may at least contribute substantially to all this. An intravesicular injection is not completely unlikely, but there are some nerves, we said, where it's more likely. Cervical nerve roots intrascalene, just anatomically much more likely than in the popliteal fossa sciatic nerve. So next to intraneural injection, there are also other things that may injure the nerve. And next to needle trauma intraneural injection, there's one complex that says chemical injury inducing inflammation, arachnoiditis. And there is the mechanical part where you say this ischemia, stress, and compression, including by hematoma. For local anesthetic neurotoxicity, the bad news is that all the local anesthetics we use, as we just said before, are neurotoxic to a variable extent. There's even not that much huge difference between local anesthetics. There may be some nuances, but there's none with a flat line where you say this is not neurotoxic. And neurotoxicity is also the main impediment for introducing new local anesthetics into clinical care. There were some promising candidates, but they all failed the neurotoxicity test. Worsening this whole thing is that we keep overdosing, that we have to keep overdosing our local anesthetics, because as also Kaylin also alluded to, our local anesthetics needs to diffuse through a lot of tissue barriers to actually make it to the sodium channel. And these include the epineurium, all the fat around it, which McLeod and Rayner have described as circumneurium, so that is the connective and fatty tissue around the nerve. Then the epineurium, the perineurium as part of the blood-nerve barrier, has an especially sharp drop in concentration, the endoneurium, the plasma membrane, and then we know only a part of the local anesthetic can come across the plasma membrane. It has to conjugate with hydrogen, so we lose local anesthetics all the step of the way. So we overdose local anesthetics to still have enough concentration to drench all the nerve. And we typically overdose by a factor of 40 to 50. So if you took out a segment of a nerve cell and just looked at the channels with nothing around it, and the amount of lidocaine, or the concentration of lidocaine better, to numb the sodium channels is 1 millimolar, but we inject between 40 and 80, just to give you an idea. So provocatively speaking, most local anesthetic molecules that we inject for high volume blocks never see the sodium channels we actually want to block. They're just there to make a concentration gradient to drench the nerve and all its fascicles and all the axons. The good news is that we are abandoning some of the dangerous practices that we had. So we don't use the high concentration of lidocaine anymore. We don't use the intrathecal catheters anymore. So there are some things that we do to move our practice to safer. And I would hypothesize that probably the biggest thing to help us do this is it really has a mind of its own. It's very funny. So the biggest thing I think to help us is that, and I drew this for you. It's not very beautiful, but it did draw this. So it's meant to illustrate that we are coming down with the volume of local anesthetic that we use to do these blocks. No? From this to this. Right? So when you look at the old description of the interscalene block, they had 40 to 50 cc of 0.5 bupivacaine. That's when I started training, when I was littler. With the stimulator, you put this into the side of the neck, if you imagine this. And now if we do 20, we already say, oh, maybe that's too much. Maybe 10, 15 is enough. So this is the advance that we've made, the graph that I made. So this is huge. It's a huge advance and should, if anything, make everything better. And then I would like to anchor into one more thing that Kaylin said, and that is that most often nerve injuries are not that pinpointable. So you can't say, well, I injected here, I injected 5 cc too much, that's why the patient has neurotoxicity now or something. It's not that easy. But most often it's multifactorial, most often it's not that easy to see. And speaking of multifactorial, if you wanted to say, is it really multifactorial? We would need to take a symptom complex that's a little variable, and to learn about it, and one of them is transient neurological syndrome. It's not very prominent anymore, but it used to be a big thing in the 2000s. It's a transient neurological syndrome is defined as a just purely sensory radicular pain irritation that persists after a spinal wears off. And so what we can learn from transient neurological syndrome is that if you have different medications, without going into the details, you see that different medications have different propensity to elicit transient neurological syndrome. So, for example, lidocaine and mepivacaine have more chance of eliciting this irritation than bupivacaine, so there is a drug component. But then if you take people who have lidocaine for the spinal and you put them through a spinal, and then you have different types of surgery, some may require lithotomy position, some may require supine position, then the difference is huge. It's a factor of 5. Whether you get the TNS as well. So it's a prototypical syndrome, an example of a combination of pharmacology and mechanics. So it's a prototypical confirmation that sometimes these nerve injuries, these irritations are just multifactorial. I would like to point you towards this ASRA practice advisory on neurological complications, which not only tells us a lot about the pathophysiology. It not only lets you know a lot about the protective things you can do to avoid these nerve injuries, but it also addresses that we're not the only elephant in the room, that there are 2 elephants in the room. One is the regional anesthesia, and one is any sort of neuropathy associated with the surgical procedure itself. And then we do these blocks often for orthopedic procedures, and some of these procedures have very high neuropathy rates or new onset neurological deficit rates. For example, if you do, like in pediatrics, a derotation and a lengthening of the long bones of the lower extremity, your chance of neuropathy is between 10 and 30% from the procedure itself. And then we add our little thing on top of it, but we're not the only ones, and shouldn't accept the blame as soon as something happens. And then we come back to the incidence of the injury. Like you already said, that there is the peripheral injury, 3% short term. Most of those recover, and this incidence is steady. And then the interesting thing is that with neuraxial blockade and neurological deficit afterwards, the likelihood is much lower, but the chance of recovery is much smaller. And this incidence is rising, maybe not only or not because we're getting worse at it, but because the denominator is changing completely, and most patients that actually at one point had epidural anesthesia were low risk, they're not getting epidurals anymore. So that's why I think artificially it seems that we're having a rising incidence, but it just reflects a different patient collective. So peripheral nerve, relatively high incidence, pretty excellent prognosis. Neuraxial, low incidence, but if something happens, the rule of thumb is a third will get better, a third will have a partial recovery, and a third won't get better. Second summary, all local anesthetics are neurotoxic. That's the first takeaway. The doses used these days are getting lower, so that's good for us and good for our patients. Most perioperative nerve injuries remain ambiguous in origin, are likely multifactorial, and we used transient neurological syndrome to just explore a little bit the interplay between drugs, chemical, and mechanical stressors. Peripheral nerve injury is more common but heals better. Neuraxial injury is less common and the prognosis is worse. The take-home message is what happens when you inject intraneurally. The old view was that you cause a mechanical disruption. The new view is that there is at least a substantial component of injury and inflammation that contributes to the whole pathophysiological effects. Can you actually pierce a fascicle? Yes and no. It likely depends on the nerve anatomy. We looked at the C5 root versus the sciatic nerve just to illustrate those 2 completely different nerve anatomies, different tissue contents, to say the injury is different. The effect of intraneural needle position is substantially different in these settings. What mechanisms for nerve injury are related to regional anesthesia beyond that? Beyond the needle is the local anesthetic, then chemical injury, arachnoiditis, maybe something for the discussion, and then all mechanical stresses like stretch, pressure, and compression. How does central and peripheral injury differ? The central is less common than the peripheral, but the prognosis is better the more distal you come. So all these together should hopefully encourage you to keep practicing regional anesthesia, to approach each nerve block as if it was known to be a calculated injury to the nerve, and to continue to provide regional anesthesia to our patients because we know they benefit from it and it makes their perioperative period much, much better. Thank you so much.
Thank you, Philip. Next up is Dr. Brenda Gantz. Dr. Gantz is the chair of anesthesiology at the Crichton Medical School in Phoenix, and she's also the chief of anesthesia at District Medical Group. And she's going to be talking about all the risk factors for injury and nerve localization techniques.
So I feel really lucky because I get to have the fun portion of this talk. This is actually going to be a clinical scenario. It's actually based upon a case that really happened in my hospital. So the title of our talk today is Other Risk Factors for Neurologic Injury and Guidance Surrogate Localization Techniques. Again, I'm Brenda Gentz. I have no conflicts. Learning objectives, we're going to learn about other risk factors associated with regional anesthesia techniques, the benefit of guidance surrogate localization techniques, and remember that neurologic injury is not always related to our peripheral nerve blocks. Well, we've all started our day feeling like we have the Midas touch, where everything we touch is going to turn to gold. And then this happens. Everything turns to mud. And it all starts out, it could happen to anyone. Your orthopedic surgeon, Dr. Smith, he books a 58-year-old woman with a right-sided ankle fracture. She sustained the injury last week when she fell off a curb in front of her house. Her history, of course, is diabetes. She has hypertension, sleep apnea, GERD, morbid obesity with a BMI of greater than 40. She doesn't speak English and is experiencing significant anxiety. The orthopedic surgeon comes up to you and says, they're really interested in a regional anesthesia block in your patient. So you consent the patient for an ultrasound popliteal adductor canal block after completing a neurocheck. The patient has a slightly diminished sensation from her diabetic neuropathy, but can dorsiflex and plantar flex her foot. You attempt to image the patient's leg, maximizing the depth and gain to visualize the canal and neural structures. Using an interpreter, you gently remind the patient, please remind me if you feel anything that's like an electric sensation at any time. Then, 2 weeks later, the surgeon, Dr. Smith, he finds you in the hallway and stops you and mentions the patient's having a very slow recovery, and he's concerned that there might be a foot drop, and he mentions to you, by the way, did you have any difficulty when you're putting in your block? So what happened? Well, one of the things to think about is your risk factors. Is it the patient? One of the things that's really hard is when you're in a very fast-paced environment, sometimes I feel really challenged to do a neurologic evaluation ahead of time and make sure I'm doing a complete one. Because many times you find out the patient already has pre-existing numbness and you didn't account for that. So we actually created a area in our chart where we can note that the patient has neurologic deficits. So that's something to think about in your documentation. So again, is it the patient? Pre-existing neuropathy, diabetes, anatomical variations, and remember lumbar spinal canal stenosis because they might have fewer paresthesias. There's other extremes of body habitus. This patient has a BMI of 40. Do they have vascular disease? Again, other neuropathies. Interestingly, if patients have comorbid medical conditions, depression, anxiety, alcohol, tobacco, and if they have acute intensity of pain at the time of their injury, they're actually more likely to convert to someone who has a chronic pain issue. And that actually occurs in 77% of patients with severe musculoskeletal trauma. But interestingly, there's very weak evidence, or there's not much evidence, that indicates that regional anesthesia actually has a preventative role in chronic pain development. So is it the drugs? We talked about a little bit about that already because local anesthetics do have an effect on neurons, including the effects of calcium homeostasis, reduces the mitochondrial metabolism and increases oxidative stress, increases the rate of cell death. So if you have low doses of anesthetics or low concentrations, you're more likely to have problems with apoptosis. High doses can induce necrosis. And again, we know there's a difference in LD50 and the different drugs. But the one thing to always remember is, do you use the correct drug? Are you using the wrong drug? Using wrong concentrations, wrong doses? And be very careful because sometimes people can pick up the wrong ampule and put the wrong drug into your peripheral nerve block. So risk factors, is it the adjuvants? If you get a nerve injury, you always worry about adjuvants. Is the thing you're putting into your block to try to make it last just a little bit longer causing the problem. Most are safe and actually have little or no adverse events or effects. But the risk-benefit ratio always has to be evaluated. So they're extensively used clinically. I think a lot of us use adjuvants in our blocks, just trying to get that little bit of extra time. But each adjuvant can, in and of itself, have its own side effects. One, we use them because they prolong the duration of the block. It may eliminate the need for a continuous catheter, and that's not the catheter, it's a kidney that's in there, but it's actually not that type of catheter. Reduces risk of catheter-mediated infections. So what about adjuvants? Which ones appear to be good? Well, the good ones are alpha-2 selective adrenergic agonists, which actually provide you with analgesia, hemodynamic, and sedative effects. Clonidine is one of the drugs that was used. It was pretty popular for a while, but it can cause hypotension, bradycardia. And at least my experience is we had one patient in the PACU. I could not get her discharged for anything because her systolic pressure was in the 80s. She was a nurse, and she mentioned to me, hey, you know, Dr. X did put Clonidine in my block. And I was like, oh, that's it. So it can cause some hypotension. It can last for a while. I think the most popular drug now, people are using a lot of dexmedetomidine. It can prolong peripheral nerve blocks by, 3-4 hours or longer at a dose of 1 mic per kilogram. But it also can cause some hypotension and some bradycardia. Dexamethasone, very popular. I was using it a lot for a while, using it a little bit less now. It may act as a potassium on the potassium channels on nociceptive C fibers through the glucocorticoid receptor. Doses, most people use about 4 to 10 milligrams, and this can increase your block duration by about 3 hours. The only thing that made me pause a little bit was when I was doing research about dexamethasone, there was some evidence in vitro studies and in mice models that there was some potential increase in peripheral neurotoxicity. What about narcotics? They tend to cause a lot of side effects but don't increase your duration. There may be some potential use in buprenorphine down the road. Less favorable, lack of evidence, tramadol, toradol, adenosine, neostigmine. Neostigmine has a lot of GI effects. People are using a little bit less epinephrine. It was very popular 20, 25 years ago. But I think if you go back to our patient who's diabetic, it can decrease the nerve blood flow and cause increased neurotoxicity in diabetic rat models. So maybe that's a problem with humans as well. Don't use magnesium. Magnesium causes really severe nerve damage in animals, especially with intrathecal administration. People have actually put in midazolam, surprisingly. That also is probably a no. Ketamine causes a lot of psychiatric side effects, and there was no enhancement duration of block. People have used verapamil. That may help a little bit too. So there's always, when you have a neurologic injury, there's always a question, is it the positioning? Well, I say that there's 6 culprits, and they said maybe 7. First one is traction, transection, compression, contusion, ischemia, stretching. And we all sometimes wonder if it's not the surgeon because there's no data or any studies out there that indicate that there's a problem with one surgeon over the other. But certainly we do see more nerve injuries sometimes in one practitioner over another. So maybe something related to their technique. So in this patient, what are you worried about with positioning? Maybe a common peroneal nerve injury causes weakness in ankle eversion and dorsiflexion and sensory distribution of the dorsal foot. But this patient is not doing things that are necessarily high risk. She doesn't have a low BMI. She's not a smoker, and she's not going to be in lithotomy for more than 4 hours. So positioning doesn't seem to be an issue here. What about a vascular cause? Can you have hypoperfusion, prolonged use of tourniquet? There's nothing worse when the surgeon says, oops, I dropped something on the floor, and then suddenly they've got to take the tourniquet down, then they got to put the tourniquet back up and start over again. Those are the patients that I worry most about getting some kind of complex regional pain syndrome issue or having some kind of nerve injury. Also vascular compromised related to the block. If you get a hematoma, that can also compromise your nerve. You always think about the equipment. Is it my equipment? Long versus short needle? Is it a cut versus blunt needle? How large is the diameter of the needle? Where is the tip of my needle? Well, what about using a continuous nerve block in this patient? Well, probably not indicated if she's just going in for one surgery. But we do get these complex patients that are coming in that have fractures, soft tissue injuries. And if you know you're going to have repetitive procedures where you're going to do debridements, fracture fixation, skin grafting, you might want to put a catheter in and put in like 0.1, 0.2 ropivacaine and run an infusion. And then you can actually, if the patient's coming back multiple times, if you can keep your catheter in, you can rebolus it. And there's actually pretty low risk. Buckenmeyer did a study with 187 patients. These were combat veterans, so they're probably almost all pretty healthy ahead of time. And most of the complications related to kinking, dislodgement, superficial infection. And I will tell you, my biggest challenge is, even though I tunnel my catheters, dislodgement's always my biggest challenge. Oops. So, is there a higher risk if you put a peripheral nerve catheter in? Well, where you put the catheter in actually matters. And not talking about where you put it in the patient, it's the location. They're finding out that if you put in these catheters in the ICU, in the emergency room, other locations are more likely to get infected. If your catheters stay in more than 48 hours, If you use prophylactic antibiotics, less likely to get an infection. Stimulating catheters may be associated with an increased risk of infection. I think it's actually the movement may cause some tissue trauma. In burn patients, I come from one of the largest burn centers on the West Coast. You just be careful not to put your catheters through an area where the patient's been burned because of the loss of protective barrier. And just keep watching out for infection, inflammation, watch out for your immunocompromised patients, and your incidence of complications still should be low at 0 to 3%. So now with this patient, she's got a high BMI. What kind of technique are you going to use when you're actually going in and putting your block in? So the guidance and surrogate localization techniques includes paresthesia, gives you about a 38% needle to nerve contact, peripheral nerve stimulation 75. You can use ultrasound guided techniques, you can use dual combination techniques, and you can do injection pressure monitoring. So one of the things you could do, and what was done in this similar patient, was that you can actually combine, if you want, all three. So one of the things you can consider is using your peripheral nerve stimulator not to localize your nerve necessarily, but to use it as a safety tool. So what is recommended is you can set your nerve stimulator at 0.5 milliamps, 0.1 milliseconds, and the current is not manipulated. And when you get a motor response, then you know you have needle to nerve contact. And this is really important when you can't see the nerve very well, because sometimes when you get patients that are larger size or have a lot of swelling, it just looks like a very fuzzy cloud when you go in there. So this is where it's really helpful. So if you get a response at 0.5 milliamps, the recommendation is you pull back the needle 1 millimeter, wait till you lose your stimulation, and then you inject 1 to 2 milliliters of the local anesthetic. And if you want to check pressures, you can add in your manometer and check and make sure that your opening pressure is less than 15 psi. So if you don't forget, if you have motor responses less than 0.2 milliamps, you're probably intraneural. So again, back out. And if you use a peripheral nerve stimulator, the hard part for me is it's always having that extra piece of equipment. You have to have a special needle. So that makes it a little bit more difficult. And if you add a pressure monitor in, you're adding a lot of devices in. So to me, sometimes if I can see well enough, I will not add that in. But if I get someone where it's just very hazy, I will go ahead and use a peripheral nerve stimulator. So this is actually an algorithm that's in NYSORA that you can look at. It shows that if you have needle to nerve contact at 0.5 milliamps, you advance the needle towards the nerve plexus, and then you can, it says if you go over to the right, if you have poor imaging like you might have with this patient, you go till you get twitch present, and then if you see it, then what you can do is reposition the needle so you lose your twitch. Once you lose your twitch, you inject your 1 to 2 cc's. If the distribution looks good, then you can complete your injection. So injection high pressures, if you have high pressures, both in animal and human models, that is indicative that you might be intravesicular, so you might want to pull back a little bit. And the other thing is, don't forget that we are not reliable judges of injection pressure. And I have to tell you, I'm not a big fan of having someone who's not on my acute pain team come in and help me out with blocks, because sometimes they just don't know what that feel is when you have very high pressures. But pressure monitoring can be used for a negative predictive value, meaning if you have low pressures, you're not in the nerve. So one of the other recommendations, Dr. Lurk showed you 2 syringes. One of the recommendations is that you not use small syringes. You might want to use it for volume, but don't use small syringes to generate, you don't want to use small syringes when you're injecting the local anesthetic, because you can generate very high pressures. They recommend to actually use bigger syringes, because then you can feel the changes in the pressure. And again, here's an example of a commercial disposable manometer that you can use for objective, for looking at the injection pressures. So ultrasound imaging AI, this is where I think we're going in the future. AI solutions are going to be very useful in anatomical landmark identification, reducing or avoiding complications, and they will optimize and interpret your images. They're going to help you with needle visualization and advancement, and when you're injecting your local anesthetic. The biggest problem is AI does have a really big learning curve. So it is possible that you could have AI misidentify something as a nerve or misidentify a structure. So one of the things is you're going to have some discernment when you use AI, at least at the beginning, until the learning gets a little bit better. So one of the questions I always have to ask is that the provider, I'm a lot better now at certain blocks than I was when I first started. So how many have may determine how good you are at putting in certain types of blocks. Don't forget to optimize your imaging guidance when you go in. Use of nerve stimulation can be helpful, especially if you have poor visualization like with this patient, and just be really wary when someone uses excessive force. So for book tail ending, you send your patient to see your colleagues in your pain clinic if you have one. They rule out other causes. They do an EMG if it's been a couple weeks. They consider imaging, make sure there's no hematoma. They observe the patient, they provide appropriate reassurance. You get some physical therapy, analgesics, maybe some neuropathic drugs, some non-narcotics. You avoid additional trauma, steroids, and if you have a hematoma, you might evacuate that. And your patient slowly gets better over the course of 6 weeks to 3 months. And now your surgeon, Dr. Smith, looks like this. Thank you.
Thank you, Brenda. Okay, so Dr. Gens has alluded a little bit at the management of the patient with a nerve injury. We've heard a lot about nerve anatomy, mechanisms of injury, strategies to try to mitigate the risk. But still, patients do come in with nerve injury sometimes after regional anesthetic. I have no disclosures. And so here I want to imagine that we've done a block, and then 5 days later the surgeon calls you, say, hey, I have this patient in the clinic and they still have a nerve deficit. What do we do with this? So the first thing we have to do with these patients is triage them and rule out emergencies that are reversible pathology. And those are things like compression from compartment syndrome, a hematoma, a cast. We have to rule out also a thromboembolic event and things like a stroke. And we do that by taking a thorough history, looking at what patients, what symptoms does the patient have? Are they sensory motor? Are they only paresthesias? Are they progressive? And we need to do a physical exam, looking at signs of vascular insufficiency, things like capillary refill, skin discoloration, changes in temperature, edema. If there is suspicion for any of those things happening, then an ultrasonography or a CT angio can help establish a diagnosis. And we also have to do a thorough neuro exam, which may help determine which nerve or group of nerves are involved in the injury. And we need to keep the surgery team involved through all this because some of these conditions are going to be surgical emergencies. So let's say our patient comes in, we've ruled out any of these acute reversible processes. The next thing we have to do is to make sure that this is not inflammatory neuropathy. And post-surgical inflammatory neuropathies it's an idiopathic process that can be focal, multifocal, progressive. A lot of times has delay onset. After the patient goes back to the neurologic baseline, then the symptoms occur. And many times they can present in areas that don't make sense respective to the location of the block or the surgery. Staff et al. Did a study in 2010 where they evaluated 33 patients suspected to have post-surgical inflammatory neuropathy. And the interesting thing in this study is that they realized that 7 patients that had a biopsy-confirmed diagnosis were thought to have a mechanical nature for the injury, which led them to believe that post-surgical inflammatory neuropathy is probably significantly underdiagnosed. And the greatest risk with this is failure to properly recognize it. That is because unlike many other injuries, in this case, early diagnosis can make a difference. Urgent neurological consultation is warranted. EMG and MRI changes can point towards the diagnosis, but the confirmation is done through biopsy, which will show epineural perivascular inflammation. And that's what this looks like. On the bottom boxes here, D, E, and F, you have normal epineural vessels, and the top boxes are the same vessels that are more distal location when you can see significant perivascular capillary inflammation. The treatment is immunosuppression, and as I alluded earlier, earlier treatment can impact the prognosis. Okay, so our patient comes in, we rule out acute inflammatory, or we rule out reversible processes. We also don't think this is a post-surgical inflammatory neuropathy based on the presentation. Further management is going to be determined by the symptoms. Patients that come in with purely sensory deficits are likely going to have neuropraxia or disruption of the myelin sheath. We tend to observe these patients for about 4 weeks, and that's because many of them will resolve spontaneously. But if the patient comes in with motor symptoms, progressive deficits, significant pain, or is a patient that we decided to observe for 4 weeks and hasn't gotten better, then we can consider sending them to a neurologist, along with symptom management, which includes pain control with multimodal analgesia, if that is the case. Steroids have been used in the past, and the idea is that they decrease inflammation and create an optimal environment for neural regeneration. Anxiolytics and antidepressants can help some patients cope with the stress of going through this process, and physical therapy and occupational therapy can prevent contractures, atrophy, and long-term disability. And I want to mention that both ASTRA as well as our UK, which is the Regional Anesthesia Society in the UK, have management algorithms that you can refer to that can help you in managing these patients. So our patient gets referred to the neurologist. Are there studies that we can do to help assess this patient? And what needs to be done at this point is to determine the location, severity, and the prognosis for the patient. We do have nerve conduction studies where electrodes are placed along the path of the nerve and assess electrical conduction. And they can detect the lesion very, very early after the injury happens, but at this early stage, it's very difficult to distinguish neuropraxia from more severe injuries. For that, we'll need serial studies. And different parameters are measured with nerve conduction studies. Changes in velocity or latency can point more towards neuropraxia, whereas changes in amplitude can point towards axonal damage. But they do have a limitation, and is that these studies only record signals that are transmitted through large myelinated axons, and as you know, pain is transmitted through unmyelinated fibers. So if the complaint that our patient has is only pain, nerve conduction studies are not going to be particularly useful. We also have electromyography, which evaluates electrical activity in a group of muscles that are innervated by the target nerve. And these can help determine the duration, the site, and the severity of the injury. The limitation they have, though, is that in order to detect denervation, the EMG, for EMG to detect denervation, Wallerian degeneration has to have happened. And Wallerian degeneration is part of the normal degeneration that happens after an injury, where the tissue degenerates and kind of clears the path for axonal regeneration, for the axon to start growing again. And this takes about 2 to 3 weeks, and that's why EMGs that are positive within those 2 or 3 weeks typically point towards pre-existing neuropathy. And sometimes EMGs are done earlier on to establish what the neurologic baseline for our patient is. In terms of prognosis, as I mentioned, most lesions are going to be compression injuries or transient dysfunction of myelin or neuropraxia, and they have an excellent prognosis. 95% will resolve within 4 to 6 weeks. Now, for more severe lesions, we need to determine whether the injury is limited to the axon, in which case the axon will regenerate, or whether the injury also extends to the connective tissue of the nerve or the scaffolding of the nerves, in which case there's going to be limited degrees of regeneration. And for that, we use serial electrodiagnostic studies every couple of months, which will be able to detect axonal recovery if there is one. If that doesn't happen, then it's time for the patient to be referred to a peripheral nerve surgeon to evaluate for possible surgical management. But what about imaging studies? Is there a role on imaging in the management of all these patients? And it turns out that MR neurography is able to determine the architecture of the nerve and detect lesions, inflammation, or evidence of nerve repair, but it's very expensive. And it's not widely available everywhere. However, high-resolution ultrasound is a much cheaper technology and much more available. And we actually can see fascicles, perineurium, epineurium. We can detect hematomas, neuromas, whether the continuity of the nerve is maintained or not. But ultrasound cannot show axons or myelin, which means that we cannot diagnose neurobraxias with ultrasound. And particularly high-resolution ultrasound has very good resolution, but low penetration. So images are basically limited to about 2 centimeters from the skin. Now, this is the ultrasound image of a long-axis view of an ulnar nerve on a patient with ulnar neuropathy. And as you can see, in this area where the arrow is, the nerve is thickened and hypoechoic. And this corresponds to an injury class 1, 2, or 3, which will not require surgical management. On the other hand, this is a patient with a forearm laceration, and this is also a long-axis view of the ulnar nerve. And here, where the dotted arrows are, they're pointing to normal nerve anatomy. But the solid arrows here are pointing to what's called a neuroma in continuity. Now, neuromas happen, this is pathognomonic of an injury class 4, which needs surgical management. And neuromas happen when the connective tissue or the scaffolding of the nerve is lost, so the nerves, the axons start regenerating in a disorganized fashion. And it's in continuity because the epineurium is not affected, so the nerve hasn't lost its continuity, and we can see that under ultrasound. As you recall, for the prognosis and the management of these patients, we're going to need serial electrodiagnostic studies to determine which patients don't have regeneration, and we need to send them to the peripheral nerve surgeon. But the problem with this is that by the time we make that determination, many times the optimal window for nerve repair has already passed. And that's because chronic exotomy and denervation renders the tissue less likely for, or suboptimal for axonal regeneration. And we know that repairs that are delayed more than 4 months have a 66% reduction in the number of axons that can regenerate. And that is why a paradigm shift in the way, traditional way we were managing these patients is occurring, where some of these patients are getting ultrasounds very early. And that is because we want to diagnose these high-grade injuries for which we already have described signs, so that we can refer these patients to the surgeon earlier on. And similarly, there are proponents of using MR neurography to, again, identify these high-grade injuries for which, again, symptoms or signs have already been described, to refer them to the surgeons earlier on. Okay, so our patient unfortunately gets to the point where we send them to the peripheral nerve surgeon. There are different techniques that can be used. Direct nerve repair or epineurial repair. It's done whenever the 2 stumps of the nerve can be repaired without significant tension. If there's a gap that's too big between the 2 stumps, a nerve graft can be used, where a section of a nerve is transected and then used to bridge that gap. And nerve transfers usually involve transecting a nerve that we want to deprioritize, and then anastomosing the distal end of that nerve to the nerve that we want to treat. And this is usually reserved for complex motor reconstructions. But epineurial repair is a gold standard, and that is because despite best surgical techniques, there's still a mismatch of fascicles when we anastomose the 2 stumps, and there's fibrosis at the repair site. And as a rule of thumb, approximately 50% of axonal loss is lost at each coaptation or anastomosis site. So with a direct nerve repair where there's 1 coaptation site, 50% of the axons are able to regenerate, but with a nerve graft where we have 2 anastomoses, only about 25% of the axons are going to be able to regenerate through. It's important throughout all this process to reassure, not necessarily provide false hope, but reassure patients that most peripheral nerve injury do self-resolve. And it's also very important to maintain thorough documentation of every interaction with the patient, the findings of our physical exams, the management plan. All this facilitates multidisciplinary coordination of efforts, or there are multiple specialists that typically get involved in the management of these patients. And clear documentation can also confer medical legal protection should that be required. Thank you very much. And we'll be happy to take any questions now that the audience may have. If not, thanks, and enjoy the rest of the conference. Okay.
In regards to like upper extremity nerve blocks, have you guys changed your practices for concentration for reducing risk of nerve injury?
No. No.
Like what
No,
concentration?
So we would typically use a concentration that so I think we use for pretty much everyone else uses. So for if you use bupivacaine as the gold standard or something, then we'd use 0.5% for if we want a surgical block. Anytime that the block is a supplement, so that means there is also general anesthesia, then we would do 0.25% and then 0.125 on the floor for the continuous blockades. Sometimes there is very rare exceptions, and those rare exceptions are actually, so one I can think of is we had a patient that had a lower extremity fracture, was at high risk of chronic pain. The surgeon evaluated that patient and deemed the compartments to be reassuring, and we did a block starting with 0.125% right from the start to not mask too much in case anything should develop. But in otherwise it's just 0.25%. 0.5, 0.25, and 0.125. And we would typically not deviate from that, especially for the surgical blocks, because the last thing you want to do is to have the patient won't have to convert, especially when the indication is good, like Brenda said, when you have a really good indication in your patient. For a surgical block, like the one we had, was also a polytrauma, and he had like rib fractures and altered mental status, something going in his brain. He also had a complex ankle fracture. We were able to do everything with a nerve block.
I think compartment syndrome, you're right, though. Compartment syndrome is the one where I drop the concentrations if I'm worried about it. But I think they've had a couple of studies that were done at the University of Miami where they've used 0.125 ropivacaine, and they didn't mask any compartment syndrome. So that's the one time I'll drop down as compartment syndrome for sure.
Yes.
So like for long bone fractures,
Mostly
Yes.
for tibia fractures, and if we've had a couple arms where we've had interscalenes or other blocks that affect the arm.
And and I guess so. There is clinical studies that say that a compartment syndrome pain, like this really intense pain, should break through a low concentration block, and then I think that's the concept that the nerve block that we do is not like a wall that we put up to shield everything from impulses, but it's more like a puddle we create that's Garris Rickards, like a big puddle on the street for the nerve to come through. But if the impulse is forceful enough and strong enough, it will get through. And the deeper the puddle is, that means the deeper the concentration is, the more hard it's going to get through. So there is one study recently that I was lucky to be a part of, and then we evaluated like in a healthy volunteer model of compartment syndrome, and where we could show that if you use a low concentration like 0.125%, you delay a little bit, but it will break through just a little longer. If you use 0.5%, you will mask compartment syndrome and the ischemic pain for a long, long time, if not for too long. Thank you.
Amanda?
My question is about like identification and monitoring these patients that have the nerve injury. A lot of times we hear them as they come back, we hear about the injuries, or we hear about it from the surgeon, or they call some random nursing line. And I didn't know if any of the institutions have a good way to track and follow some of these events, and if you think we're missing more because they just go underreported or unreported.
Yeah, so I mean, I think the incidence of earlier within the first 2 weeks is very high. Like many patients probably have blocks that last more than we think it's normal. But many of those also, the majority resolve spontaneously. And I think each institution has a different system based on their setup. I think at my institution, mostly we hear from the surgeons on their post-op visit. And if that is the case, then we typically bring the patient to our chronic pain clinic so that we can actually see the patient in an office setting. And then from there, take whatever steps we think are best, which most of the times involves just observation for a couple of weeks, because most of them go away. But if that's not the case, then we engage other consultants too.
We send all of ours to the pain clinic. There are pain doctors are part of our acute pain team. So we transfer all of our patients who have potential nerve injuries to the pain clinic so they can be followed in clinic. We found that to be the easiest way to do it.
Yeah, well, what Dr. Gens mentioned that they have a flag in the chart to flag the patients that have had issues in the past, even if they resolved spontaneously. So that's something that you also want to keep in mind when you're doing another block, particularly if it's the same location. You might want to be more conservative, or maybe keep it as an analgesic block as an option if the patient is not doing well without the block. All those are things that you want to think about. Yes.
Thank you for your excellent panel presentation. I had a question for you regarding postoperative follow-up in the case of a nerve injury. Oftentimes, our patients are referred to neurology with a persistent deficit, and oftentimes that follow-up can be very long. I work in a VA system. Sometimes it can be 6+ months, and I was shocked to see that your recommendation would be a surgical intervention in the most severe of cases within 4 months. Would you say that evidence strongly promotes advocating for patients to be seen within a 3 or 4 month period, or what would you recommend?
I would say so, and then like what I can tell you at our hospital, there's one surgeon that typically deals with this, and I think like most hospitals really have the one person that. Most large hospitals have the one surgeon that tends to see the patients that have nerve injuries from different etiologies. And in talking to him, he very much prefers the patient to see the patients earlier on in the process as opposed to after 6 months, because the thought is that the prognosis for those patients for the chances of successful interventions are lower once you go definitely past 6 months. What we do, let's say like we see a patient, we observe for a couple of weeks, it's not getting better, we decide something else needs to be done. We also refer the patients to a neurologist, but they almost invariably always get an ultrasound at that point, even sometimes before an EMG or nerve conduction studies. And the ultrasound is also that the surgeon is going to want to have when they see the patient. So, at least our hospital, getting an ultrasound is also, there's a very, very long wait list. I think like ultrasound or radiology technicians that do the ultrasounds are in very high demand. So they have long wait lists. So if, we activate that process earlier on to have all things in line so that if it gets to the point where we send them to the surgeon, they already have all the tests done and they can think about, scheduling the patient for surgery if that's what they think needs to happen.
Thank you.
Yeah.
This is a great question. You do your block sedation pre-op for acute pain?
I do very little. I mean, sometimes I'll do a little bit of narcotic. I might, but I try to actually just use straight local. I don't use a lot of adjuvants, or I don't use a lot of sedatives when I'm doing my blocks.
We use quite a lot of sedatives, to be honest.
I think.
How painful actually would inject intraneural?
Oh, when you've injected intraneural? I've seen one intraneural injection when I was supervising a resident, and just like, the Far Side cartoon where the mosquito's in the artery and it's like, get out, patients do get, if you have nerve-to-nerve contract, they usually do have an electrical feeling. But you're right, I've never seen it really mass, but certainly I think the biggest worry is if you give too many sedatives, you do worry about masking that, but I've never seen it mass so far.
What I do have to say, we do a lot. We have lots of. It may have happened to me too. Or I don't know. So it's not. So in general, you sometimes see that. You're sometimes mistaken about where the nerve is, where the tip of the needle is, and you try to visualize it. You try to guide the residents, and they may be too far in. I think what I have seen and what I think is reflected in literature is sometimes it's very inconsistent whether you do get a paresthesia, even though you're very far in. You try to inject a little puff, and you think.
Yeah.
Yeah, it's also.
I think so. So it's very inconsistent, and it's more inconsistent, I think, in bigger nerves, like the sciatic nerve, or if you're. So then it really becomes very, very, very inconsistent whether you even get a paresthesia. But I would agree, too heavy sedation is probably not safe. I think it depends also on the setting. Like work before. We did lots of blocks preoperatively, so then we would give some sedation. Now we do lots of the blocks postoperatively after neurochecks. It's just the way the system has grown. And some patients still have a little bit on board from the surgery. And then the needles have become very, very cutting. The needles have become very tolerable. I think especially for single shot. Then we tend to not add too much sedation on top of that.
But I will tell you, when I saw that intraneural injection, there was part of me that had a pre-syncopal moment.
Yes.
But I was like, oh my God, he's in the nerve, because I could actually see it blow up a little bit, because when he injected the volume, and I was like, oh my goodness. And I said, you're in the nerve, stop, you're in the nerve, you need to pull back. But interestingly, going back to what Dr. Lurk was talking about, that patient did not have a nerve injury. So, sometimes it depends on whether you get into the fascicles or you're just within the sheath. And we were just lucky we were in the sheath, and everything got big, but the patient did well.
And there have also been case series of patients with nerve deficits that didn't resolve, that didn't have any paresthesia, didn't experience any paresthesias or any symptoms while the block was being done. So, like Philip was saying, it's very inconsistent. Obviously, if you have a paresthesia, adjust what you're doing. And if you see that the nerve is blowing up when you inject a little bit of volume, again, adjust what you're doing or do something different. We also, and practices vary amongst hospitals, but we topicalize the skin with a little bit of lidocaine to try to minimize the amount of sedation that the patient needs to tolerate the injection.
I have a question regarding the risk of this two-hit phenomenon of causing a nerve injury. So I work here in town as a regional anesthesiologist at Oak Medical Center. We have a lot of trauma patients that have nerve injuries that come in. How do you approach those patients that they're going to have horrible postoperative pain, but they already have a known injury? Should we block them? Should we not block them? How do you kind of approach that problem?
Well, I think the first thing we do is talk to the surgeon, and many times they don't want to block in those patients. Whether that's the right thing to do or not, it's debatable. But I think you definitely, for polytrauma patients that are going to be pretty missable post-op, if we decide to go ahead and block them, we are very, very, very cautious in what we're doing. And us, for example, won't probably have a resident do the block. We'll have either a fellow or the attending do the block themselves. And that's also a little bit of, being protective, because the least amount of people that are involved in those cases, probably the better in case there's a problem afterwards. But don't use any adjuvants, definitely no epinephrine, and use the lowest concentration of local anesthetic that you think is going to help the patient without, trying to minimize the neurotoxicity that you're imposing on the nerve that's already somewhat injured.
And if I may add, I think it's always a weighing of risks and benefits, right? And one thing that I think I gather from literature is that the clinical relevance of the double crush syndrome is a little bit less in the forefront of people's minds than it was like 10, 15 years ago. And we have seen that for example, it would be typical for diabetic neuropathy, right? But lots of diabetic patients get blocks and they seem to be okay. So it's not as if, how really daily, when it is that relevant to make us completely change our practice is debatable. But then you have those patients where I think in the overall treatment it would make a lot of sense. It would help them a lot in their clinical progression through the care continuum to have those blocks and to have good pain. And I would maybe argue, if I may, that would be a good indication that outweighs the risks, the potential risks. I think this double crush phenomenon was described by Borja in one case and by Mr. Hebel from the Mayo Clinic. I think in quite specific settings. I think one was for chemotherapy-induced neuropathy, where people had nerves that were really severely pre-damaged. For most people we see in daily clinical practice, I don't think it's a huge concern that should make us shy away from doing a block, even continuous block, and right full is accounted. Whenever we can use a lower concentration, we should. And so that's why I'm very happy that we're very happy to, for example, if it's not a surgical block, we drop the concentration automatically to half, and then we drop it even more for the blocks. And there is a provision we could even drop the BPVIC into 0.0625 if someone was really very sensitive. So there was other concerns. So that is.
Yeah, you'd be surprised, injured nerves, they need a lot less concentration of local anesthetics. And you've done blocks on, for toe amputations and things like that on diabetics that have significant peripheral neuropathy. You can get a surgical block with 0.25% BPV gain or even less concentration. And you can tell when you're doing the block, they're really not feeling your needle to begin with. So those patients do not need much of anything to block their nerve function completely.
And I was just going to say the emergency room doctors now are doing regional anesthesia, and it's going to be part of their curriculum. So we've decided to jump into that space to be involved in teaching them, because if we don't, they're going to be doing them without us. So one of the reasons to do neuro exams is I started finding out a lot of our patients were getting regional anesthesia blocks before they were coming to us. Now, some of their order of doing things is a little interesting, like they sedated a patient that needed to have a joint manipulated and put back into space, but they did the block after they did the sedation. I would have done the block before the sedation to maybe get a better outcome. But just be aware that your emergency room counterparts may be doing regional anesthesia blocks before you ever get the patients. And, if they injure the nerve, you injure the nerve, that could increase the risk. So just make sure they're not having any issues when they come to you already.
All right, thank you, everyone.